Hi, welcome to ISSUP UK chapter webinar. The title of this webinar is Drugs Policy in the UK, a matter of crime or health. I welcome everybody listening in the UK and from around the world. Okay, a disclaimer from the start from ISSUP. Please note that this webinar is provided for informational purposes only and does not constitute medical or treatment advice, and the views presented here are those of the speakers and not necessarily those of ISSUP. So with that official announcement out of the way, welcome very much to this webinar. My name is Annette Dale Pereira and I am today's moderator. We have an exciting line of speakers from the UK, and this includes Dr. Anne Campbell, from the Scottish Drug and Alcohol Research Network from Northern Ireland, and she's on the ACMD. Justina Murray, who's the Chief Executive Officer of the Scottish Families Affected by Drugs and Alcohol. And we've got Martin Blakeborough, who's the Chief Executive Officer of Kaleidoscope, that offers a range of substance use disorder treatment and recovery services. And he's also the Director of Developing a Caring Wales. And he'll be speaking today in relation to Welsh drugs policy. Let me introduce myself, if I may. So I'm Annette Dale Pereira, and I'm the Chief Executive Officer of NOFAR Substance Use Disorder Treatment Services in Doha, in Qatar. I previously worked for international agencies, including the WHO and UNODC, on substance use disorder treatment and prevention. Before that, I did work in the UK for over 25 years and was a member of the ACMD, Strategic Director of an NHS Trust on substance use disorder treatment services and offender healthcare. And I was previously a director at the National Treatment Agency for Substance Abuse in England. Now, let me introduce today's webinar before we get into listening to the speakers, if I may. So I think it's a very interesting topic, and I think it's got relevance for many audiences. So drugs policy, laws, regulations, and an agreed course of action and procedures is important to every country in the world. Drugs policies and frameworks, the laws, the agreed policy goals, and the strategies for delivery for different geographical areas, they vary greatly between countries, and even sometimes within countries, and between the different parts of the countries, whether that's provinces or states, or in the UK, the devolved administrations. As we all know, that there are heated debates sometimes on drugs policy, and particularly on the interface between goals and the emphasis on drugs and crime in different types of drugs policy. In drugs policy, we often think about this in terms of drug demand reduction, which involves substance use disorder treatment and prevention, and restricting supply, which might be limiting the production, supply, availability of illicit or illegal drugs. Both aspects are important in any drugs policy. Now, I think drugs policy is becoming an even more complex issue than previously, not least because psychoactive drugs, although they're sometimes thought about as just illegal, bad substances to be prevented, actually the term encompasses many more things. It does include illicit or illegal substances where there may be a risk of harm, but psychoactive substances also may be medicines, sometimes recommended essential medicines, such as some of the opioid painkillers, where access is recommended for evidence-based healthcare, even though that access may need to be regulated or there may need to be some oversight. This is a changing area as well, particularly in relation to things like cannabis and cannabinoids, and issues concerning whether or not some of the cannabinoids are recognised as medicines or have medicinal purposes. So the area seems to be getting even more complex. Drugs policy is also quite complicated because we do have international laws and frameworks and conventions that may be enacted or even interpreted differently in different countries. And then this takes us into a territory about policy issues around whether drugs or drugs use or possession or supply is illegal or decriminalised or legalised? And if it is, for what drugs? And if it is, for which people? For who? So, drugs policy may try and address issues such as how much access is there to illegal or illicit psychoactive substances and medicines, and how should that be permitted? It may also have issues such as things like what are the cultural or religious norms in relation to drugs and alcohol in that particular country or territory. And it may focus on how can we prevent harm or damage to communities or individuals or families caused through drug use and drug-related crime. One of the aspects that we also should be aware of when we're talking about drugs policy, and particularly national drugs policy or devolved drugs policies, is the political element, and how much of the drugs policy or strategy is rhetoric for purposes such as to win votes, and then how much is real in terms of what is actually undertaken. So there's so many different elements to consider when we're thinking about drugs policy. Now, today's seminar will look at examples for 3 out of the 4 UK countries approach to some aspect of drugs policy and the interface between health and crime. Now, for our international listeners, and at the risk of telling you things that you already know, the United Kingdom is made up of 4 countries: England, Scotland, Wales, and Northern Ireland. England has the biggest population at around 53 million. Wales has a population of around 3 million. Scotland has a population of around 5.3 million. And Northern Ireland has a population of around 1.8 million. So you can see England is very dominant in terms of the size of the population. Now, this ISSUP ceremony is not presenting the English drugs policy. And I think that this is an interesting choice by ISSUP UK, as historically and in terms of governance, England has dominated UK drugs policy for as long as I can remember, and probably as long as the policies have been there. And indeed, there is a UK drugs strategy that was published in December 2021, and it's called From Harm to Hope, a 10-year drugs plan to cut crime and save lives. Let's guess the emphasis within this strategy. Now, some would argue that this is a UK government strategy rather than a UK strategy, and then with an emphasis on implementation plan in England. Now, all of the devolved governments of Wales, Northern Ireland and Scotland have their own strategy or strategic approach or plan. And this is different. They are different from the English plan, not least because of the different levels of devolved responsibilities and fundings and different emphases, etc. So this seminar to me feels a little bit like a family gathering without the dominant sibling taking all of the attention. So this can have some advantages, and I personally think that a lot will be learned from the different approaches taken by the devolved administrations of Scotland, Northern Ireland and Wales. And I think we can all learn from them. I do think it's also valuable for listeners from the UK and international listeners, many of whom come from countries where the responsibility for drugs policy and strategy is devolved or partially devolved from a national level or a state level to a provincial level or state level. Okay, so that's enough of my kind of brief intro. Can I remind listeners to please use the chat function and put your comments in there while the speakers are presenting. At the end of each speaker, we will reflect back to them some of the dialogue that's happening in the chat. So your input is most welcome. And then at the end, I'll ask all 3 speakers to come together and try and have some dialogue between the speakers and also involving some of the chat function. So please do write your comments, your observations in the chat. And I will be asking you in the chat, what do you think? Is drugs policy a matter of crime or health, and why? So we would welcome contributions in relation to all of that. So we have almost 250 people online already. So great, that's a welcome to everybody. Please do participate. And I would like to welcome our first speaker, which is Dr. Anne Campbell from Northern Ireland. Anne, would you like to join me? So
yes.
over to you.
Thank you so much for that wonderful introduction, Annette, and you really set the scene in the context. And I love the analogy of the dominant sibling not being here. We're probably the smallest sibling in Northern Ireland and probably the one that creates the most noise. So quite proud of that in terms of our drug policy and our drug work. So I'm just going to try and show my screen now if I can do this. Hopefully people can see that. Yes?
Yes, we can. Yes, we can.
Great. Fantastic. Thank you. Okay, so you did give us some overview of the different nations within the UK. And as you see there, that smallest nation is Northern Ireland, which is part of the larger island of Ireland. But we also have this connection as part of the UK with Scotland, England, and Wales. And we have a population, as Annette said, of approximately 1.8 million, probably closer to 1.9 million people. And we have a devolved government, and some of the issues are still lie with the Westminster government in England. For example, the Misuse of Drugs Act 1971, we are still bound by that legislation, but we do have our own health policy, health budget, drug policy, and drug budget. I don't usually hark back to these images of our conflict. We had a period of conflict, otherwise known as the Troubles, in Northern Ireland from 1969 until the ceasefire in 1998. I think it's probably the first time I've shown these images as part of a presentation, because it does have direct relevance to our drug situation and our drug policy. So the picture in the middle is of the Omagh bombing, where 29 people lost their lives and 120 people were injured. The image to the right with the police vehicle and police was actually taken 2 years ago. So we still have incidents at certain times of the year where certain sections of the population still feel very strongly about some of the issues, the leftover issues from our conflict. So what does that really mean for drugs policy and drugs context? The Good Friday Agreement, which marked the end of the Troubles to some extent in 1998, we expected our drugs context to change quite quickly after that, but it didn't happen. We thought we would have the same problems as our major city, our capital city of Ireland, Dublin, which did have and still has huge problems with heroin, opioids, other opioids, and polydrug use. So we think primarily that did not kick in 1998, those surmised problems, because of our situation in Northern Ireland was such that the paramilitary organisations still had a grip, a hold on the drug market, and we did not, as a result, see some of the problems that we anticipated. But a lot has happened in the last 25 years. Our drug use prevalence surveys would show that cannabis remains the drug of choice for the general population, and also is the commonly reported drug within our treatment services. Our deaths, unfortunately, have increased in the last 25 years. We had minimal numbers of deaths pre-ceasefire, but now we see that incremental and exponential increase in our drug deaths. Our rate of heroin use in the north had decreased in comparison with the remainder of the UK. But again, we've seen an increase in heroin-related deaths, other opioids, and an increase in the use of cocaine in our drug toxicology reports. We also have a huge problem with the misuse of prescription medication, primarily benzodiazepines. And again, harking back to the Troubles and the conflict period, we had particularly women who were prescribed benzodiazepines, and now we see that pattern of that particular type of drug use from grandmothers to mothers to daughters to granddaughters. So we have the use of prescription medications, the misuse of prescription meds, usually benzos, alongside the use of street benzos as well. This has been further compounded and exacerbated by the increase in what we call designer or research benzos, which are highly potent, which are easily available online, and which we are seeing, most importantly, in our toxicology reports. A lot of our young people are mixing these designer benzos with opioids, and we have seen an increase in deaths as a result. So that's the piece of Northern Ireland. If you remove it from Ireland, that's the area that's covered. And the small dark piece in the middle is what's called Belfast and the greater Belfast area, and that's where we see the highest concentration of deaths per 100,000 people. So our deaths have increased. We do not have the same numbers as our counterparts in Scotland and England, but by head of population, we have seen those deaths rise over the last, particularly since 2010. The thing that stands out in Northern Ireland is that our age group, our 25 to 34-year-old age group, is that grouping which is experiencing the greatest number of deaths. So we have a lot of young people in that age group dying because of polydrug use, and we are really struggling with how to tackle this, how to address this, and why is this happening in Northern Ireland. Other areas, of course, Scotland has the highest death rate, but for us, our death rate in the 25 to 34-year age group is something that we're really wrestling with at the moment. And our new drug policy is trying to address that, as well as our newly established drug-related deaths task force. So the policies, there have been many since 1999. With separate strategies for drug and alcohol use, which wasn't really the best way forward. But since 2001, we've had joint implementation of those two strategies in relation to drug and alcohol, with the most recent one focusing on, in 2022, preventing harm and empowering recovery. So the new strategic framework, I think for me, the biggest sort of point in relation to this was we had a huge consultation period to inform the policy. And I think this was more by accident rather than reasoning, because our devolved government in Northern Ireland still does have a hiatus. They are not sitting because they are arguing over certain issues that I'm not going into in any great detail, because it would probably take me a day to explain our strange situation in Northern Ireland. But it did allow us to consult with a number of people across our people who use services, across the voluntary and community sector, across the statutory sector, our strategists in the PHA, the Public Health Agency, and also in the Department of Health. So really, we were part of that consultation over a long period of time. So the themes that came up, which had not come up in previous policies. The first one that was talked about time and time again in that consultation period was dual diagnosis or co-occurring mental health and substance use issues and services which are not available in the way that we would like to see in terms of breadth and coverage in Northern Ireland. So that was a huge theme in our latest policy. Stigma was also something that came through time and time again, and increasing the involvement of people who use our services. They were represented in that consultation in a non-tokenistic fashion, which was a fantastic departure from other policies. Other ideas which I think come up time and time again in policies is the old chestnut of more holistic and flexible joined up services. We talk about this all the time, but I think it's a difficult one to pin down in relation to bringing services together across a multidisciplinary framework. But nevertheless, it was pointed out again within this latest policy. Our waiting times, we were not very proud of our waiting times in Northern Ireland, particularly for OST. We had, at one stage, we had waiting times of up to 26 weeks for OSTs, and people were slipping through the net, being shunted between services, and ultimately lives were lost. Fortunately, now we have tackled that and addressed that, and we are improving, but there's still room for more improvement. Focus on prevention as well as treatment came through, increasing support for our young people, because, as I said earlier, and I really wanted to underline that, in Northern Ireland, our young people are suffering, they are dying, and we are struggling to get to the root of the issue and help our young people. Also, not losing the focus on alcohol, which came through time and time again from a health perspective, because our alcohol-related deaths have also increased exponentially per head of 100,000, per 100,000 population. We have a huge problem with alcohol. So all in all, there was little focus in comparison, I think, with the English strategy, if I may say that, in terms of a punitive strategy or the criminalization of people. Ours is a health-focused policy. So I'm not going to go through this, but I think in a pragmatic way, our policy is now working through specific outcome groups for some of those issues that I've just mentioned. And the strength of that, again, for me, is the involvement of our people who use services within those outcome groups in a non-tokenistic fashion. And there was a number of things that we're working on in terms of evidence base, monitoring and evaluation. These are terms that we've heard time and time again through successive strategies. And part of me thinks that, yeah, we've been here before. How do we do things differently? Yes, we do have a health focus, but how does this policy translate importantly into practice? So what do we need in Northern Ireland in terms of translation of policy into practice from a health focus? Again, just to say, our focus on young people and those drug-related deaths. We are seeing in Northern Ireland, particularly again for our young people, more complex cases, more trauma, intergenerational trauma, the severity of the drug use, the numbers of drugs that are being used, and almost the sense of nihilism from some of our young people in relation to whether they wish to continue to live, basically. So I think that's something that we need to think about in terms of a policy and practice approach. The integrated approach, I said here, old ideas, yes, we all want to push and see that, but we need a new framework of working. And we're currently involved in some community-based initiatives from the ground up. We're working in an area within Belfast that for various reasons, do not wish to work with our local police force because of the history and the legacy of the Troubles. But we have worked with them quite closely in terms of what they need, what they are demanding in terms of support for families, support for themselves, support for their young people. So for us, going back to the community and working it from the ground up is a way to integrate policy in a meaningful and non-tokenistic fashion. Also, trauma-informed practice, because as I've mentioned before, our transgenerational trauma, we still have our young people and our older people who still experience the legacy of the Troubles. We still have our paramilitary gangs in operation, still involved in the drug market, still involved in the drug supply. And according to some sources, allegedly, some of that market has been sold to organizations from outside of the country, if I can put it like that. So there's a tussle going on at the moment, I think, in terms of our drugs market and who controls it, which is having a huge impact on our young people. Focus on families and carers came through very strongly in our policy, and talking to our community representatives. Tackling structural issues. Now, to me, these are issues that are endemic to the places where we work, the people who we work with. Poverty, transitions, for example, from care into out of care, into society and living independently for young people in care. Issues around housing, education and meaningful employment. And these are things that we have been talking about within policy and within practice for years. But there are some great examples in England of how we are bringing this together, and a good example in Northern Ireland via a project called Complex Lives. We are looking at the wider structural and community issues and not simply getting to the end of the firefighting with our people who are in great need and our people who are dying. And lastly, I'm just going to mention, it's not in our policy, but we've been quite successful in Northern Ireland in pushing for, lobbying for, and getting to the point where we may, or moving towards, the opening of an overdose prevention centre in NI, in Northern Ireland. Now, because we are linked or enmeshed in the Westminster legislation, our Misuse of Drugs Act 1971, we will not get this through changing that legislation, but we are trying to navigate and work our way around that in different ways. And we've just been successful in getting the Belfast City Council to pass a motion to support the opening of that. And I just want to end on that note. And really, from the Northern Ireland perspective, we are pushing the health-based agenda from all avenues and from all directions. Thank you.
Hi, Anne. Thank you very, very much for that fantastic presentation. And I think that you've said lots of things that are really interesting for the UK, but also to listeners from around the world. And we do have listeners from around the world. I've already got questions coming in from people in Kenya, Philippines, Nigeria, etc., including a couple of specific questions from you. There's an interesting one come in from Adan from Kenya, who's asked, he wants to ask you whether or not you think it's possible to harmonise drugs policy in the UK and just have one. And I'd be very interested in whether or not you think that that's a good idea or not. And I am going to, a heads up for Justina and Martin, I'll also ask you guys this one as well. Yeah. What do you think?
Great question. Thank you, Adam. I think because of the particular problems across the UK are regionalised. So, for example, I talked about our young persons' deaths and how they've risen exponentially. Also, the different drug types. I know that Scotland would have a larger problem with heroin than Northern Ireland. So I think specifically there are issues that are endemic to the region, and I think that demands a policy response regionally and locally. So I cannot see how a wider UK drug policy and elements of that would work specifically for Northern Ireland or other regions. I hope that answers your question.
Thank you very much for that answer, Anne. And can I say that that's the first time I've seen the Troubles mentioned in a presentation from Northern Ireland in a while. So, and thank you very much for that. Sadly, I think that that's incredibly relevant for lots of countries around the world that have their own troubles or conflict or war or civil war. Sadly, we know that this has quite a big impact in terms of substance use disorder, need, drug supply, what happens afterwards, etc. So I'd like you to thank you for that, and then thank you for talking about the very important issue around trauma and the need for trauma responses at the community level and at an individual level. I think that we've had quite a few ISSUP seminars in the past couple of years on the need for trauma-informed care and to know more about and realise the impact of trauma, particularly on substance use. So that was a great reminder there. It was very interesting to hear about the different patterns of use and the patterns in different age groups. And I was saddened to hear about the levels of drug use deaths in your young people. And also interested in looking at how you hearing from you that the policy is not just about the drugs issues, if you like, but it's also about trying to tackle some of the structural elements. I thought that was very, very helpful. You know, the poverty, the housing, some of those real underlying elements. I thought that was very helpful. We had another question for you, and this is from Tim Gluckman. And he wanted to ask an interesting question about how much you thought Northern Ireland was impacted by some of the things that were happening across the border below you in Éire, in terms of some of the gang conflicts, and whether or not some of that was coming across the border into Northern Ireland. For listeners, Southern Ireland area is not in the UK. So this is another difference with Northern Ireland. There's another land border with another country, a European country, I have to say, part of the EU. So I thought that was an interesting question. Yes. So perhaps you'd like to answer that one as well.
Yeah, great question, Tim. Thank you for that. Yes, for most people, some people don't recognise the border, I have to say. And some people do recognise the border, depending on which area you live in or where you're from in Northern Ireland, or what your past or your political views are. So it's very important to state that, I think. In terms of drug issues, and you mentioned gang issues, yes, very much we are affected by what happens in Dublin, because some of the organisations obviously don't recognise the border either, and they supply drugs and they enforce some of their summary justice, for want of a better word, in the north of Ireland. So we've had a number of shootings, people coming from other parts of Ireland into the Northern Ireland region, and a number of fatal shootings because of those drug gang wars that are happening. So I mean, there was one most recently a few weeks ago. So yeah, that's happening, unfortunately.
Thank you very much, Anne. We've got people coming in from all over the world asking questions. It's really interesting. South Africa, Philippines, etc., Pakistan. Lots of people asking for the presentations to be sent. So we'll ask the presenters whether or not they're happy to share them as well. And we've also got a number of different people asking about the Overdose Prevention Centre and how that's going to operate, etc. And some questions there. If you'd like to make a quick comment on that, and I think I'll bring that in at the end, if I may, as well, Anne, if that's okay.
Okay,
So question for you is in terms of the overdose prevention centre that you mentioned. Yeah.
Yes.
So there's some questions about how is that going to operate, and can it happen without the Northern Ireland government meeting? So there's some questions coming up. I can park those if you want.
Well, I'll answer that very briefly, because we could talk and talk and talk about this. It's such an interesting and vital part of what we're trying to do to address our drug deaths, particularly in young people, and because they are rising so fast at the moment. So OPCs, there have been a handful of people who have lobbied for an OPC in Northern Ireland for the last 15 years. So, and it's difficult to work in an area where at the moment there is no government, but we are working behind the scenes. We're working with people in England and in Scotland to try to circumvent the Misuse of Drugs Act 1971 and work in a way that we could possibly have an MOU with the local police, with the local government, and introduce the OPC in that way, because we realise it's not a panacea for all ills, but we do, and the research does support the fact that an OPC is necessary, particularly within our environment. Our colleagues in the Republic of Ireland and the island of Ireland have had a change in legislation which has enabled them to open an OPC, but they have been dogged by consistent problems in relation to different planning applications. So that route seemed to be the perfect route to do it, get a change in legislation, but they've had their own problems with that. We are trying a different way to get around the MDA, and we are hopefully now, it's in the embryonic stages. We've just had the motion passed, but we will push further to do that and work with our colleagues in England and Scotland to effect that change.
Thank you very much for that, Anne. Thank you very much. That's great. I'll bring you back in at the end if that's okay.
Thank you so
great
much.
presentation. Thank you very much indeed. There are some more questions coming through, and I'm going to bring those in at the end and also answer some by email as well, if that's okay with people. Again, lots of international contributions coming through. But next, I would like to introduce Justina Murray, who's the Chief Executive of Scottish Families Affected by Alcohol and Drugs. Justina, welcome. I know that your presentation is going to be very relevant to many of our listeners, so over to you.
Thanks very much, Annette. So I think we're going from the smallest, noisiest sibling, to use Anne's analogy, to maybe the awkward middle child, and I say that as an awkward middle child myself. So thanks very much for the invitation to be part of today's Drug Policy in the UK webinar. I've subtitled my section, which is about the Scottish experience, "Hello from North of the Border," and this phrase was used in a social media campaign a few years back in response to the UK.
Sorry to interrupt this.
Yeah.
Sorry, I think we're looking at not your presentation.
Okay,
so
thank
what
you
I'll do,
for letting me know. What are you
no
looking
worries,
at? Send me the.
we were looking at, I'll send you the notification again.
Okay, try again. Thanks for letting me know.
No worries.
Okay, I can see now. Is that better?
No, still the notes. There we go. Now we've got it.
Great.
Perfect. Now the PowerPoint.
Take two. All right, thanks so much for letting me know. So our phrase "hello from north of the border" was used in a campaign a few years back in response to the UK publication Charity Times naming the 25 most influential leaders from across the sector and not including a single name from Scotland, Wales or Northern Ireland. So it's really great to be included in our own right in this look at drug policy in the UK, rather than creating another Stushy, as it was described at the time, and using a great Scottish word. So my perspective today is going to be influenced by the fact that I'm CEO of a charity called Scottish Families Affected by Alcohol and Drugs, or Scottish Families for short. And we support anyone concerned about somebody else's alcohol or drug use. So, you know, that involves a wide constellation of family members. And given we're focusing on the impact of drug policy differences in the UK, I'll be looking through the lens of families, in particular in the Scottish context. So the Scottish Parliament held its first meeting in May 1999, and it can debate any issue but only legislate around devolved issues. So those are prescribed in legislation, with anything not devolved to the Scottish Parliament described as reserved to Westminster, that is the UK Parliament. In a clever move, the Scotland Act lists a number of reserved matters, but otherwise everything else is devolved to the Scottish Parliament, and this has ensured a more comprehensive approach than listing everything which is devolved. So the list of reserved matters is consequently much shorter and includes matters such as constitution, defence, immigration and foreign affairs, and also drug policy in terms of the Misuse of Drugs Act 1971. So this issue being reserved to Westminster, of course, wouldn't matter at all if the UK government and Scottish government were aligned in terms of their approach. But of course, they're not aligned at all, as we're exploring today, with the Scottish public health approach to drug policy very much in contrast to the criminal justice approach taken by the UK government. And for me, this was really strongly evidenced at the UK Drug Summit held in Glasgow in late February 2020. And that was an event which really became particularly memorable over time because it was held just a few weeks before the UK's COVID lockdown. So it was the last large-scale in-person work event I attended for almost 2.5 years. Both Kit Malthouse, then UK Government Minister for Crime and Policing, and Joe Fitzpatrick, then Scottish Government Minister for Public Health, spoke at the summit, although only Kit Malthouse left halfway through, I think it's worth noting. And in a repeat of that Scottish word I taught you earlier, there was a stooshe, or another one of my favourite words, a stramash, before it even happened, with Kit Malthouse initially refusing to attend a Scottish Government drug summit before announcing the UK government would host their very own summit in Glasgow. So we ended up with a Scottish summit on day 1 and a UK summit on day 2. So you really couldn't make this stuff up. Before the UK summit had even happened, Kit Malthouse gave media interviews dismissing Scotland's call for safe drug consumption facilities as a distraction, which was just being used as a kind of silver bullet solution. At the drug summit, his proposals focused on crime and policing, including proposing a cross-border policing roundtable to tackle the drug trade. In contrast, Joe Fitzpatrick used the platform to announce £20 million of additional funding to reduce drug harms and drug deaths, including establishing a drug death task force, mental health support, and additional residential rehabilitation capacity, saying, "We have listened to people with lived and living experience." So the Scottish Government's drug and alcohol treatment strategy, launched over a year previously, is called Rights, Respect and Recovery, and takes a human rights approach and is firmly situated within a public health framework. The strategy vision reads, "Scotland is a country where we live long, healthy and active lives, regardless of where we come from, and where individuals, families and communities have the right to health and life, free from the harms of alcohol and drugs, are treated with dignity and respect, and are fully supported within communities to find their own type of recovery." In 2019, the Scottish Affairs Committee of the UK Parliament at Westminster, so this is a cross-party committee of Scottish members of Parliament, held their own inquiry into drug use and misuse in Scotland. They took extensive evidence, including from families, and here I am with a group of family members who travelled to London to give evidence. The committee concluded, "The criminal justice approach to people with problem drug use has failed. Problem drug use is a health issue and it should be treated as such by the UK government." The committee called for a substantial reform of the Misuse of Drugs Act 1971, for the UK government to declare a public health emergency, to recognise people experiencing problem drug use require help and support, not prejudice and judgment, for a decriminalisation approach, and to transfer responsibility for UK drugs policy from the Home Office to the Department for Health and Social Care. And it's important to note the committee did also include a critique of the Scottish Government's own track record, saying much more could be done within its existing powers, but there was recognition that at least Scotland was starting with the public health framework. In the midst of the committee's work, Scotland's most popular tabloid newspaper, the Daily Record, publicly called for decriminalisation, which really brought this whole debate into the mainstream. One of the areas where the UK and Scottish approaches have clashed most publicly is around safe drug consumption facilities, also known as overdose prevention centres. And there's widespread support for these to be developed in Scotland, including support from politicians, NHS, Police Scotland, local communities and businesses, and families. There's been extensive scoping in Glasgow in particular about developing such a facility, but Scotland's previous Lord Advocate, James Wolfe, who was head of the Prosecution Service, stated in 2017 that this could not proceed within the law and he would not issue a letter of comfort to staff that they wouldn't be prosecuted. However, the current Lord Advocate, Dorothy Bain, said in November 2021 she might consider a specific and precise proposal committing to reconsider that position. In the meantime, a campaigner and activist, Peter Prykant, ran an unsanctioned overdose prevention van in Glasgow for a period to prove this could be done safely. He was in fact not prosecuted for this, and it's worth reading more about his whole story, including a very positive and robust academic evaluation. So interestingly, we can also see real divergence in drug policy within individual political parties, comparing UK level and Scotland. So for example, while the Conservatives are in power at Westminster and continue to promote their tough on crime drug policy approach, in Scotland, where the Scottish National Party or SNP are now reaching their 16th year in power, the Conservatives are in opposition. Yet the leader of Scotland's Conservative Party, Douglas Ross, who's pictured here with our own current First Minister, Nicola Sturgeon, visiting a community drugs project, has proposed his own Right to Recovery Members' Bill at the Scottish Parliament. And this would enshrine in law the right to treatment for problem drug use, including access to residential rehabilitation. The bill proposes a statutory right to a range of treatment options, such as short and long-term residential rehab, community-based rehabilitation and medication-assisted treatment. Furthermore, the bill seeks to prevent individuals from being refused treatment from alcohol and drug services for reasons such as medical or criminal history, and allow for individuals to choose a preferred treatment option unless it's deemed harmful by a medical professional. So, what's it like to be a family member affected by a loved one's drug use in this nirvana state of public health in Scotland? Well, to be honest, not as good as it should be, and there's many reasons for this. In Scotland, we really have a very progressive legislative and policy agenda, not only represented in rights, respect and recovery, but also the National Drugs Mission, which now underpins this. We've also got a set of medication-assisted or MAT standards, medication-assisted treatment, or MAT standards, which specify national standards for the delivery of drug treatment, including access to same-day treatment, choice of treatment options, psychologically informed and trauma-informed services, access to advocacy and support for wider needs, housing, welfare, income and so on, as well as mental health care. And I would say in Scotland, we're very, very good at writing down excellent and evidence-based and progressive commitments as to what we're going to do to improve the lives of individuals and families and communities. But this doesn't just apply to our approach to drugs policy, but it's particularly notable here. What we're less good at in Scotland is implementation. In summary, we don't always do what we say we will do, and we don't often check whether anyone else is doing what we've asked them to do. So when individuals and families highlight this discrepancy, they actually find very little accountability in the system. Their concerns are dismissed, and they're directed towards slow, cumbersome and remote formal complaints processes as their only route of redress. Linked to this, in my view, is Scotland's reliance on statutory public sector services to deliver drug and alcohol services, with a relatively small and poorly funded third sector of charities and community and voluntary organisations. So the vast majority of funding for treatment, care and support services is swallowed up by these predominantly NHS-led services, with a reliance on medication-driven treatment delivered by health professionals. So this is clearly in contrast to other countries where the third sector is funded to play a stronger role, offering a more holistic, person-centred and relationship-based approach. The What About Families report was published by Scottish Families Family Reference Group as a companion report to Scotland's Drug Death Task Force in July 2022, and it reported patchy implementation of the MAT standards across Scotland, a lack of accountability in the system, including an over-reliance on self-reporting of progress by services, rather than listening to families or individuals' own experiences. There was little evidence of the required cultural or attitudinal change within treatment services, poor progress in delivering family-inclusive practice or support for families in their own right, and really just an ongoing invisibility of families in the system. The What About Families report called for an independent body where families could feel safe and confident to raise concerns. They called for a presumption of family inclusive practice to ensure family members are partners in care, similar to other long-term and chronic health conditions. Mandatory training for services in family inclusive practice, a specific MAT standard for families, and faster implementation of Scotland's stigma strategy. So the implementation gap in Scotland between what we say we will do and what we actually do in practice has also recently been mentioned in a couple of really good publications, one by Scotland's Mental Welfare Commission into the poor response to people with co-occurring mental health and substance use issues called Ending the Exclusion, as well as a recent report by the Health Foundation into Scotland's persistent level of health inequalities in the post-devolution period. Another area where we've made endless commitments is that of family inclusive practice in treatment and care, as shown in this detailed policy timeline. So we've stated many times that families should be involved in their loved ones' treatment and care and be involved as partners in care. And my colleague Scott Clements produced this very insightful and colourful, but actually quite depressing timeline of all the times that family inclusive practice has been mentioned in Scottish policy over the past decade or so. And there's a lot to take in. I'm not expecting you to be able to read it, but you will get a copy. But really the take-home message is that multiple policy and strategic documents have made commitments to including families in the treatment and care of people using alcohol and drugs, but there's clearly something getting in the way for families. What they routinely experience is being judged and stigmatised and excluded. And these are all real comments that workers have said to me and to my colleagues. It was Peter Drucker, the management consultant, who said, "Culture eats strategy for breakfast," and families remain quite cynical that the same treatment staff who have stigmatised, judged and excluded them and their loved ones over many years are suddenly going to become different people and implement every aspect of the medication-assisted treatment standards. We hear stories from families every day about ongoing poor practice, which is actually increasing risk and harm to individuals and not reducing it. And families don't need to look far to find examples of a punitive and judgmental culture within statutory treatment services. I could provide you with an encyclopedia of quotes from family members about this, but here's a couple. "My son asked me once to come into his GP, and the GP said, 'With all due respect, he's an adult, and really the day for his mum sitting beside him has passed.' It was very patronising, and I was put out, and I wasn't allowed to be there. You know, that kind of still sticks in my throat, because there's nobody knows my son better than me, and all I would want to do would be only ever to be a support to him. Anyway, I was excluded from that." Another family member talked about taking her son to a psychologist appointment following a 6-month wait. He didn't want to attend, and she drove him there while he cursed at me all the way. When they reached the appointment, she said, "He went in and ranted and raved at the psychologist about the terrible mother that he had. And she said, 'Well, you know, I think you might need to cut your mum out of your life while you're working with me.' So that's what he did. He came out and said that he'd been advised to cut off all ties with me. So that was quite heartbreaking for me. That was 6 weeks. All that did was reinforce to me that I was a bad mother and a failure, and the guilt was horrendous." So to conclude, there's much to celebrate about Scotland's public health approach to drug harms and drug deaths, but there's also much to improve before our written commitments look and feel real for individuals and families on the ground. Thank you. Annette, you're still muted.
Am I?
That's you now.
Can you hear me now?
Yes.
Yeah. Justina, quite brutally honest in many ways presentation, and I think that you touched on many important aspects that are clearly having resonance with the attendees of this that are now at over 314, which is fantastic. You talked about the politics with England and the interfaith and what it's like to have this dominant sibling and legal framework where Scotland is trying to push this very strong public health agenda from a policy perspective. You talked about, again, the tragedy of drug overdose deaths, etc., that you're facing. I thought that your reflections on the voluntary sector, or in international language, the NGOs versus the statutory sector, and your reflections in relation to that were really, really interesting. The emphasis in Scotland on stigma, and the fantastic work that I think has been done in Scotland on stigma and on getting the voices of people who use drugs and the voices of families impacted by drugs. It's been a very strong and a great strength, I think, of the work that's done in Scotland. And then your really interesting reflections on the gap between the policy, the current gap between the policy and the practice on the ground, and the need to improve quality, which is an issue that's very close to my heart. So thank you for those extremely interesting comments that have been coming through. There's all kinds of questions that are coming through, and things like from different countries. There's Antoinette from the Bahamas who says, an observation: we're realizing that there is nothing new. We are facing many of the same challenges. Isn't that interesting? We've got people coming through and asking for, how do we tackle some of these drug-related deaths? So we've got a question from John in terms of the drug-related deaths. You know, many of the people are aged between 25 and 54. What specific targets can we give? There's questions on, are there any drug treatment courts? There's questions on things like, is there any recovery support housing? I don't know if you want to pick up any of those issues here.
I can quickly pick up on some of them, and oh, how I would love to be in the Bahamas, because it's actually snowing outside the window, as I can see over the top of my laptop. So every year Scotland publishes its drug-related death statistics, and every year they get worse and worse. Or last year they barely changed, which was definitely not what you call an improvement. And we called for a 0 drug-related death target. So we thought we really, you know, we go on and on about these deaths are preventable, and yet we've never really set a target. So we think there should be a 0 drug-related death target set. And a lot of the work that's gone on in Scotland has been very much focused on the deaths. We've had a drug-related death, we've had a drug death task force. We've also had locally based commissions in places like Dundee and Renfrewshire, also looking at these issues. But I think for me, I don't think we need to do more around the policy and legislative framework. As I was saying, I think we've got that in place. It really is all around implementation. And if we did implement everything we said we would do, we wouldn't have the level of deaths. And so I think, again, we do need to get really down to the level of what is happening on the front line in terms of culture. You know, if we have written down services should be high quality and accessible and treat people with dignity and respect, but that's not people's everyday experience. That's not an issue to do with the policy or the strategy. That's an issue to do with implementation. So as an organisation, we're shifting our focus down to frontline practice as well, to see what we can do to support services to really get